And as we all know, technology has been advancing at an unprecedented pace, and it is no different in the healthcare industry. From portable ultrasounds to 3D printing of organs, new screening technologies have the power to transform the way we diagnose and treat patients. Keeping this in mind, let's start the panel of the topic, Disrupting Healthcare, How New Screening Technologies Are Revolutionizing Medicine, and see what our panelists have to say on this subject. I would like to invite on stage our moderator for this session, Yasily Ogando Roa, VP of Quality and Regulatory Affairs at DeVilbiss Healthcare, and our panelists, Shawn Nason, Chief Executive Officer of OFFOR Health, and Dr. Osama Kandalaft, MD, Associate Medical Director and Assistant Professor of Internal Medicine at CareMedica Family Practice in Yale University, and Dr. Jeremy Koenig, Head of Business Development at Sequencing.com. Thank you.
Right now, we are seeing 5G. But back when COVID came, this is when we wake up and saw how technology really was impacting healthcare. We had telemedicine, 3D printings, right? That is being used in surgeries. We had the watches band that we use to monitor our heart pressure, oxygens, and so on. Also DNAs, as Jeremy recently presented to me. Very, very nice job, and looking forward to hear more about that. And I would say, as we continue this, there are pros and cons. The pros are good. We're going to be preventive. We're not going to be reactive. We're going to be going to the root cause of the illnesses. The cons, a lot of data to collect, to manage, cyber attacks. We have to validate our software. And we have to have very good regulation. And right now, FDA is heavy in what it is data integrity. I'm going to pass it to my colleagues now.
Awesome. Good afternoon, everyone. My name is Shawn Nason, CEO of OFFOR Health. We are a pediatric anesthesiology company where we provide anesthesiology to pediatric dentists. But I've been in healthcare for several years and really talked about what disruption is for a lot of years and have been known for it. And I think this is kind of interesting, and we didn't really talk about it here as a panel, but I think disruption has become a fluff word in the space of healthcare, much like the word innovation. Like, what the hell does that mean? What is disruption? What is innovation anymore? Yes, it's all happening so fast. What I have seen in my years, 15 years in healthcare, is this pendulum swing of everything must have a technology for it. So I lost track of, I think it's 3 million and something apps out there for healthcare now. So it's ridiculous. And in 2019, something like $68 billion was being invested in healthcare startups. And that we've seen a decline in that, because what's happening now is, how do you figure out to still stay high touch and high tech? Because the one thing in healthcare you can't do is take people out of it. And we as people want connection. We want to have that relationship. I never knew, I've worked in experience, and particularly patient-provider experience, for a lot of years. But last year, April 15th of last year, I was diagnosed with stage 3 colon cancer. I really didn't care what technologies were out there. What I wanted was a very educated doctor that knew how to deal with my cancer, and I had a relationship with and could walk me through that journey. So really I think the disruption comes in, how do we balance using tech as a way to help clinicians be able to take better care of people? So, pass it to you.
Okay, so, kind of going in through this journey of disruption, kind of going through the journey of how I came across, at least, to change up how we're doing in terms of the norm. There's, a very kind of conceptual concept in medicine regardless, which is, providing the best possible quality care over to your patient. And I think and this may be a slightly difficult thing to say in general, one of the benefits that we've seen from COVID, the benefits from COVID is that it showed how fragile and how inflexible our systems are for adapting to change. My personal definition of disruption is more so of focus on building something new outside of the norm, outside of the regular route and vein of what we're used to and what we're comfortable with, but move into something qualitative. Aim to build something with a purpose that gives benefit to people down the road as we are building it. The difficulty with it is that we don't really know where it's going to lead. And this in particular comes into the discussion of AI, which has probably come up something, 5,000 times through this conference so far. This isn't the first time it's come up. It won't be the last time it's come up. But the idea of disruption, if you have a piece of cloth that you want to work with and you want to make a dress out of it, you have to cut it up in particular ways to be able to make it. But if you keep tearing at that cloth, you're not going to be left with anything. So I agree with you fully. It's that balance between finding the qualitative and new. And it's going to be a gradual process in and through. And I think us as a culture and a society, innovators from all different departments in marketing and IT, in technology and engineering, in medicine, in legal, bureaucratic, genetics, engineering itself, it's going to be a very shared and cultural effort for us to finally get to that stage where we're building something truly qualitative. That's kind of it. And I won't bore you guys with my story in general, but it's a long one, and I will ramble about it if you guys ask me about it later on.
Thank you. Thank you very much. Koenig from sequencing.com. So I'm the head of strategy and strategic partnerships business. And years. And before I go into maybe that past or the future, I had a quick question. How many people have had their DNA sequenced? Hands up. Oh, wow, the whole panel. Okay. All right, so we got around 10, and there's around 30 people in here. So I've been asking this question for about 10 years, and the numbers proportions are slowly increasing year over year. So the second question that I normally ask is how many people in the room have DNA? Okay, so that's everybody. So we are close to have every year. Right. I'm yet to meet as reported not having DNA. So, right, the first question that I think okay. Yeah. I think about I talk to say again? I worked quite a bit as an entrepreneur as well, and with various startups, and saying that you're going to disrupt an injury has kind of become like a badge of honor. I don't know if you guys have come across that, but I think about disruption more in as really a byproduct. I think when I think about organizations like, say, Airbnb, where I don't think Airbnb started to disrupt the hospitality industry or the hotel industry. It was really, folks would show up to a conference like this, as an example, and hotels would be fully booked, but there would be lots of empty rooms, and somebody had invariably an air mattress, and so we could be at the conference, right? So you're really, I think, dealing with, a specific problem, and that was, not enough places for individuals to stay and have a meaningful relationship. So it was very experiential, and so then of course this evolved, and there are all kinds of, let's say. So the intended benefit is to get people to that experience, irregardless of hotel beds, right? But then there's been these unintended consequences. One of them disrupting the hotel industry, let's say, but another one is disrupting the home industry, the rental industry, for example. Where I'm from, Halifax, Nova Scotia, in Canada, housing has become an issue because landlords would rather rent their houses to an Airbnb for 10x what they would get from somebody who might rent it for a year, as an example. So anyway, with that being said, I kind of see what we're talking about, and we're going to get into like screening and diagnostics, those are interesting words to define also. But when I look at disruption, it isn't necessarily the goal, but I do see there's like a gravity in the value that we provide, and so the opportunity before us, I think, with healthcare as an example, is maybe there are some things in the screening process, in the diagnostic process, that might improve specific things that we can measure, like how quickly you can get to your care expert on an emerge admission, for example, because we have the Internet of Things, and we have you've been framed up as an individual with your holistic picture of you before you even get to the hospital, as an example. So I will pause there. Pass it back.
Yeah, I mean, it's to exactly that point. There is a systemic and there's a systematic way of how we do things. Patient shows up to the clinic, patient gets treatment, patient gets, leaves the clinic, goes home, goes to the pharmacy, picks up their medications. We're kind of set from that perspective. There is a tried and true manner in which we can actually deliver care to patients. But recently, specifically since COVID itself, we've seen the uptick in massive different areas of services right now. We have, the concierge medicine or executive medicine. We have some interest in at least telemedicine, which has been absolutely massive and is now a mainstay of how we actively see and treat our patients. Because realistically, let's give an example for a flu or a UTI, you don't necessarily need the full physical examination if this is something that's bread and butter based on your evaluation. We have concepts of DPC that are coming through direct patient care, an extremely interesting space that's being developed right now. But, again, it's still an emerging space, and eventually we're going to get to the point where this becomes a mainstay of treatments. What we're doing with our clinic right now is we're looking into the international medicine aspect at the moment, and how do we leverage our skill set, our knowledge, what we've learned here, and connect with other communities abroad in how they perform medicine and practice it. Because really, this is a globalization effort. We're gradually moving closer and closer to total globalization, and healthcare is one of those spaces, I may just say this, is a bit behind in that perspective. We're there with the research, we're pumping it out, but we do have that limited connectivity from the medical side. I don't know what you guys think about that, but I mean, that's at least some of my perceptions in terms of some of those structural changes that have been coming in.
Well, and I think this still goes back to this principle, and not a very common and happy one for most people, is we still have a system that is built to pay claims, not to provide care. And I worked for one of the big four insurance companies. I don't anymore. There's probably a reason why. But we have, going back to even what you were talking about in the beginning, in the disruptive space and getting to this qualitative space, is why are care decisions being made around how it's going to get paid for? And that, to me, even as we look at these new screening technologies, and I'm new in the dental space, and I'm learning a ton about what's happening there in the dental space. There's still basic needs of humans that have to be met in this healthcare space that we are just not doing. And so, yes, I get tired, and it's funny because I'm sitting on a panel talking about it, but I guess I get tired of just talking about disruption, when what we need to do is really get stakes and do what we do, and the main thing be the main thing, and let's take care of humans.
I would say that we have to take a step back and go back to the basis of communication, roles and responsibilities. We have end users or patients that need a service, a treatment. We have regulators, but we don't have regulations. Maybe and table without the proper regulations released at the moment, or that I fear that we are behind 1,000 miles per hour. said, to bring claims. Can you hear me now? Yes. What is the I'm going to repeat myself. So I was saying, everything comes back to communication, roles and responsibilities. Innovators are working 1,000 miles per hour bringing innovations. The regulations are not in place. How good is that? Whose role is that? Are we here to bring claims, or are we here to save life? And I think that for the whole purpose of health, awareness, medicine, is to save life. I would say it has to be a better system in which insurance companies, innovators, and the government have to come together to bring a better system. But we have to have a process for that.
A tiny bit of contribution into that as well, because I think it's not just the responsibility of the company, corporation, government that's making the rules and regulations. I think there's also responsibility that sits in with the patients themselves, the people who are actively using the software, to be aware of what it is, what it does, what the consequences are. My fiance, Jessica, she brought up one point in terms of, you know, some of the technology that we use for genetic sequencing or gene sequencing, the 23andMe or Ancestry. We were chatting about this earlier. 20%, it's a 20% population pool, if not something smaller, of the base information that we use to give us genetic markers. When I test myself and I get the results back, it's telling me I have a Parkinson's gene, but that's only based on 20% of the global population itself. It's underrepresented, but also not clinically relevant, to which we're causing a lot of harm potentially to patients, mentally, cognitively, and maybe down the line. So, you know, gonna bounce it back to you.
I think definitely the population genetics topic is something we can dive in further on. You know, basically untapped richness and diversity that we're you know, on our way to discovering. By the way, one of my favorite ideas from Stephen Jay Gould, one of my favorite authors, is this notion that the irreducible essence of biology is our variation. And so the way that we really get to understand that is actually by doing more representative sampling at the population level. But maybe before that conversation, because sequencing.com is doing some work there, specifically different indigenous populations in the US and also in Africa. But coming back to your point around patient responsibility, you know, notwithstanding there's a ton of disparity around socioeconomic status, many reasons why we're not in a position to be at our best and be our most responsible. So hopefully we have advocates, et cetera. But still, notwithstanding those points, what we're finding is with the rare disease community is a huge amount of proactivity insofar as you know, taking on their own diagnostics, let's just say. So we take an example like EDS. There's about 1.5 million of those folks globally. But if you actually zoom out a bit and ask, well, how many people have rare diseases? Actually, it's around 1 in 10. And so that's about 1 billion people, let's say. And I think it's safe to say that all of us are carriers. So the idea of you know, the way I've been thinking about DNA is DNA as a service, the way that we do software as a service, right? There's the commoditization of you know, all of these kits and reports and technologies, et cetera. But there's a huge upfront cost to getting those things going, so it takes a lot of time. So if any physician was trying to do this on their own, you know, to source the labs, the wet lab, the dry lab, to do all the bioinformatics, ensure the data privacy and security, no. So it's like, how do we take that wet lab stack, that dry lab stack, and then, you know, the physician or the expert becomes the UI on top of that. And of course you can plug in some software, et cetera. But I guess the point is, you know, so one of the two other words we were talking about was diagnostics and screening. And I don't, like, there certainly are diagnostic DNA tests that you can do, like, so the Parkinson's example again, notwithstanding the disparities, so for some populations that's actually a relevant diagnostic, but for others it wouldn't be. But the notion that there's now this whole genome sequencing, where instead of sequencing panels, you can sequence the entire genome, 3 billion base pairs, and then you can actually engineer, digital screens on top of that forever after, and that is, evolves with, the utility that the practitioner wishes to prescribe. So that could be your concierge clinics, that might be IVF, that might be Parkinson's, Alzheimer's treatment. So yeah, all.
Prescribing is basically moving through the pathway that we are comfortable with, which is what we know. Somebody comes in with.
Yeah. So in a way, there's DNA as a diagnostic. Certainly, like the EDS example. It's like, these individuals, because they're not patients yet, because they don't necessarily have anybody that would take them, because they're feeling a little. They're being told, well, maybe it's all in your head, kind of thing. So the diagnostic odyssey comes to a head where it's like, okay, I know what it is. But then the future utility of something like your DNA is not always a diagnostic per se, but a compass. So these specific moments in our lives. So again, at Planned Parenthood, for example, to find out, are you a carrier of a particular variant? What decisions might you make as a result? IVF, which embryos are you going to select as an example? Like, these are things that are happening now. When your child is born, are they born with a rare disease? Because there are rare diseases that manifest specifically in infants. Nutritionally, one example I give is, anybody seen any babies that turn orange when they eat baby food? I was one of those babies because I don't convert vitamin A, or beta carotene to vitamin A. So that prolonged deficiency results in skin issues, immune issues. So again, this is not a diagnostic. It's a compass. So.
To which, like, you're referring to one of these core concepts in medicine, specificity, sensitivity. You want the ability to be able to rule out very common conditions that are coming through. Cystic fibrosis is one of those conditions that's screened at birth with infants, because I think 1 in 4 Caucasian people have the genetic carrier risk for cystic fibrosis. Cool, so we're going to screen everybody for that, fantastic. But realistically, to check if you have a gene that may be related to Parkinson's disease, or that you may have a gene that puts you at a high risk of having colon cancer, the clinical utility for that is very limited. It doesn't necessarily change the structure of how we will screen or treat patients, but it may cause more harm and worry. I guess what we're talking about is setting up framework and structure for new developments that are emerging and coming out. Yasily, to your point, the responsibility of the corporation, not just to produce a product that is going to give us a very interesting feature or effect or something of that sort, but what is its utility? Actually something that's contributing into the health space that will benefit the patient. And I think that end sight is what's missing. It's who is the focal point of this product? Is this something fun that's there, or is this really to benefit somebody that's there?
And I can add, you mentioned the end user, the patient. It would be really nice if everybody understands the concept in one shot, but this is not a reality, right? So I have been for a long, long time providing training, and you can repeat and always come back with the same basis. I would say that it would be really good when we get to the point that people are willing to hear how technology can help them. But we need to be prepared, that's the con. How are we going to educate them? Without education, we are in the same place. Education starts where? At the school, at the homes. But sometimes the core of the house, parents are the ones that have to be aware that they have to have an open mind, that the world is changing, that we need to be open to new opportunities, but we have to be educated for us to be successful presenting this concept.
Yeah, and I'll add to this just a different perspective. So I spent 7 years working for the Walt Disney Company, and how they use data, and how they use data effectively. So I don't know about any of you, anyone been to Disney lately, or had to go through a queue? right? They know how to move people through parks so it doesn't feel like the way that it does. Like a 3-hour line doesn't seem like 3 hours unless you have an 8-year-old like I do who has autism. It's like 7 days in those 3 hours. So as we start to look at this, and how many of you have a smartphone that you're holding right now? Anyone want to share how many health and wellness apps they have on their phone? 1? Oh, you may be the only one in the room. 4 or 5? About 7? You think you've got about 20? Right? Right? Now, how many of you use those apps? Okay, wow. Do you use all 7 of those apps, though? You don't use all 7, right? So that's a prime example of where technology being disruptive is a good thing, in my opinion, right? So how many more health apps do we need to create in this country? But we still do it, right? And there's startups every day being started. We are going to create the best diagnostic app that anyone's ever had. Have you gone to shop for a blood pressure cuff lately? Like, what makes it different than any other? It takes its blood pressure, right? Like, why do we have all of these? But where Apple truly disrupted the industry is they took something that we use in our day-to-day life, a watch. How many of you wear a watch in here? How many of you quit wearing watches because you use your cell phone as your watch now, right? Like, I wear one for fancy, but I can't read it. I still pick up my phone and have to see what time it is. So, but they took something that was so basic in our life and figured out how to integrate health into it. So you, sir, are saying you use your watch so you can do stuff. I do the same thing, you know, but I have 30 apps. And when I talk around the globe about this, I don't need a doctor to look at me and tell me I need to eat healthy. I know I'm overweight. I tell my doctors, I don't need you to tell me to quit eating cheeseburgers and I need to eat this. I know that. What I need you to understand, and this came true to me last year once I was diagnosed with cancer, is what does this impact? How am I going to live a better life? What do I need to do to have wellness? And what wellness is to me may be different than what wellness is to you or to what wellness is to you. But we've tried to box this whole technology disruption thing into one simple box. And again, I said at the beginning, there's one thing you can't take out of healthcare, it's humans. And I guess I'm also tired of hearing us talk about we're going to use technology to become more patient-centered. Have you asked a patient lately if they wanted technology to be more patient-centered? Like, that's the stuff that I still think we just miss the mark on huge.
It's, a lot of it, I agree with you. I think it needs to seamlessly integrate in with the society as well, or with your daily life. There is no incentive for you. There's really no incentive for anybody to change how you're acting on your day-to-day, unless there's something that kind of helps with a prompt or an assistance, at least in terms of curving it up. So, I mean, with the watch, yeah.
10,000 steps. Yeah. How many of us got on the journey to walk 10,000 steps, whatever it was, 10 years ago, right? If you get 10,000 steps in, use this, and then how many pedometers hit the market? And then companies came out, right? Fitbit was born because of 10,000 steps. How many of you are still doing 10,000 steps today? Well, I need to take you out drinking because right? Like, I worked for Humana at the time, and we made this huge push around it. And then that's when all the gamification came around and behavioral learning and, you can change behaviors. Well, guess what? once I got to the highest status that I could get using the 10,000 steps and the gamification, I got bored with it and I quit doing it. So it didn't change my behavior. Right? So those are the things that I think we have to figure out. You look like you have a...
Burning desire to share, yeah. I think, so let's just say, if it's okay, I would want to take a turn from reactive healthcare and more proactive. And by the way, I'm not poo-pooing on reactive. Like, there's people get in accidents and you know, bad things happen. But shifting just to the proactive for a second. So I founded a DNA company focused on human performance back in 2016, and it was 2014 actually. It was way too early because we actually had to build all the apps that didn't exist at the time, right? So what it was is it was DNA at the center, and it was focused on athletes, and specifically track and field athletes. So I had a collaboration in Phoenix, Arizona with the World Athletic Center, thousands of athletes, track and field athletes specifically. So think shot putter, marathon runner, and everything in between. So different bodies, right? Very different bodies. But you know, the thing central to them is they all had DNA, they all had goals, and they all had a coach. And that was really neat. And so think about that for a second, goals. It's an extreme health goal, but it's a health goal, kind of. It's not the most healthiest thing you might pursue, to run as fast as you possibly can until the wheels come off, but that's what, you know, some people do. And you know, so what I watched was we used phrases like user engagement. You know, for an athlete who wants to run 958 and is willing to do everything to kind of sharpen the spear to get there, they're highly engaged, and they're interacting, you know, with their coach, because, well, they also only have a limited time to do this. Maybe they have 4 years to go at this. So there's an urgency around this, right? And in a way, there's actually an identity issue around this as well. And so because of that, you know, gravity, that burning desire to you know, be that athlete, you know, you had athletes reporting daily on their specific biometrics. So at the time, this was before wearables were taken off. So people were actually manually reporting on their sleep, and they were reporting on their soreness and their rate of perceived exertion with the workout. And we were able to, you know, use highly credible, qualitative survey metrics developed by exercise physiologists to actually develop what's called an acute to chronic training load ratio for athletes. And what that is a fancy way of saying this athlete is likely to get injured. And then we were actually able to adjust those scores based on genetic predispositions, and so get them on, you know, the massage table sooner, or get them in front of a chiropractor sooner, or get them in front of a nutritionist sooner, because, you know, what would happen, you know, as an example, you might have heard of high altitude training. Athletes will go and, you know, train at high altitude to increase blood volume. That works for some, but it doesn't work for others, for example, who you know, don't metabolize iron as well, or vitamin B12. So we had all this information, and we had athletes starting to make decisions on their genetics. But it was, as I said, it was implemented by the coach at the end of the day, and it was driven by this burning desire to you know, manifest their best possible form. But again, it was, what was interesting is at the center is you had this DNA, and you know, take 2 100-meter runner athletes, like a very homogeneous event, but athletes were training extremely differently because of their genetics, because of their experience, because of their vulnerabilities. You know, some would do a ton of weightlifting, and that would work for them, but that wouldn't work for others that are more reflexive and like a gazelle, so they would do more plyometrics. So the point was, is the athletes were really owning their journey. So I get to thinking about this, and I think about, you know, what about that can we learn? And again, this is a more ideal, proactive scenario, healthy people, but, you know, starting with people young, how do we get them not to necessarily be Olympic athletes? And by the way, athletes in this group, there are around a few thousand of them. If we considered the World Athletic Center a country at the time, in 2016, they placed 5th in the track and field events globally. So it was a massive success, basically, having this precision guide to your own human performance. So now what if we adapt that to not human performance for the Olympics, but human performance of your health? What are the data metrics? How do we create an environment of not necessarily an athlete, but like a healthlete, so to speak. So you take your health as seriously as you would your sport.
Yeah. No, to you know, just to dovetail off that, you know, the idea behind having so many data points right now, it's kind of an insurmountable challenge really to sift through that quantity of information that's out there. It's never going to happen with people actively running through these particular mass mountain of data without having an organized format for it. So, you know, a data scientist is going to have a question, they're going to ask that question, they're going to look for the particular pieces of information and account for that. That's the, yes. Yeah.
So the athlete wouldn't know about their iron status issue or their B12 issue until the environment triggered that knowledge. So in the same way, I've been thinking about this as like DNA moments, right? So at specific development phases in our lives, you know, from infant to early childhood to adolescent, and on and on and on. You know, what are the moments that we make critical decisions, and then what information from our DNA can pop up to help us make those better decisions. So there's this concept of marginal gains, 1% better every day, and then how does that translate?
And it's exactly that. It's the idea of not reactive or defensive medicine when we have the opportunity to be proactive about healthcare. When we think about somebody coming into the clinic, into the office, and you want to screen for the multiple different things that they're coming in for, it's again an insurmountable quantity of data for the time that a provider has to sit down and talk to a patient and work with them and diagnose and treat and counsel and focus on their wellness. And it'll never happen. The goal is, though, that when we have these types of technologies and applications and, you know, again, the emergence of AI, we now have the ability of a supercomputer at our hands where we can potentially navigate this mountain of information in a way that we've never been able to do before.
So I'm going to play a little bit of a devil's advocate here around this because, as I mentioned at the beginning, I'm CEO of a company, OFFOR Health. 98 to 99% of the patients we take care of are on Medicaid. So it's great to talk about proactive health, but again, if we aren't dealing and meeting the basics, going back to when the 10,000 step thing happened in the world, I remember I spent 9 months in the state of Mississippi doing ethnographic research to really understand what was taking place. And I had a mother look at me and say, I am more than willing to do 10,000 steps, but I work 2 full-time jobs. Who's going to have someone come and take care of my 4 children at 4 a.m. in the morning so I can get up and get those 10,000 steps? So I love the fact that we in healthcare are talking about proactive health, but we can't even talk about proactive health until we meet the basic needs for someone to be able to start looking at proactive health.
And that's exactly my point. We have to go back to the roots, family, the core. If we don't organize our life, we can have 10 apps. We can have 3 watches. We can have AI, which is at the earliest beginning. But we work in 2 jobs. We had 3 kids. We had to plan, start again, education at the core. This is my point of view. We can have right now the rocket to go to the moon, but if we are not mentally prepared to do that, we're going nowhere.
I agree with you. You know, I think with, again, the emergence of all of these technologies, with everything that comes into play, these are tools that we can use to help answer specific questions or to get us to a particular point. You know, if we have a history of atrial fibrillation or we're just interested in our heart health, interested in the activity that we're doing because we want to better ourselves down the line, we have a tool for that. We can use it, fantastic. And if that attention span, let's say, you know, with an application that comes through is 2-3 months, but we got some benefit from it, fantastic. But I agree with all of you. This is not the all and be all. An application is not going to solve everything. And this is the same thing as putting like a piece of tape over on an empty faucet. You know what I mean? It's not going to stop the leak of water.
We don't need another app.
Yes. Yes.
So if you're an app creator here, I'm sorry, but we don't need your app. I spoke to the leadership at Pfizer 2 months ago. Just in Pfizer alone, they have 96 different apps. How is that patient friendly? So I have to have, I have colon cancer, so I have one app. Oh, I'm a male with colon cancer. Oh, that's another app that you have to have. You're obese with colon cancer. Oh, that's another app that you have. It's insane to us. I know we only have 8 minutes, and we probably want to open the floor for questions.
When we have the DNA project ready to go that you presented, Jeremy, it would be easier to say, based on my DNA test, this is what I need, because this is the root cause of my problems. And then we can decide which app to follow, right?
Well, so I was thinking about developing this app. But seriously though, so I just wanted to maybe finish on this point because we did talk about it at lunch. So there's this opportunity to have a conversation with your physician. So at sequencing.com, again, it's a wet lab stack, dry lab stack, and then on top of that, you've got the patient care and the physician. But ultimately what you can do now, or you can very soon, I've done it with myself, is you can basically have a conversation with your physician and with your genome in the context of the broader environment. And so ask yourself, well, what medications might I be allergic to? I have a surgery coming up. What should I tell my anesthesiologist? So these are things that, not an app, playground, right? That's going to be the new word. But we have 6 minutes. We should probably open things up for questions if there are any.
Any questions, make any comments, please feel free to. Yeah, so thank you so much for those comments as well. Yeah, no, 100% agree. I think, it kind of comes back again to that main point, which is, again, yes, finding that pearl and really kind of delving into that one particular problem that's there. But we have, again, created so much information out there as well that really collating and focusing on one particular aspect of the problem becomes, it's a drop in the bucket in terms of hyper-focusing over on one particular aspect. Not that it doesn't give and improve healthcare, but in terms of the overall disruptive community, that's, or at least in terms of making effectual and large-scale change, maybe a bit difficult from there.
Yeah, and when it comes to payers, there's not a payer I know that's not making money. Hand over fist, right? So it is time that we start pushing back on payers to make it a consumer-friendly. We were just sharing before this, I don't know how many of you guys have done any work over in the Middle East, but I was fortunate for a couple years, about 3 years, to sit on a board for the Ministry of Health in Dubai, and my job on that board was to tell them everything they shouldn't do in healthcare that the USA is doing wrong. That's what they put me on, is because I studied those things. And it's frightening to see how messed up for such a brilliant company and the amount of money, or world, or country, and the amount of money we have in healthcare, how messed up it still is to me. So,
I think in terms of communicating about sandboxes, the tools and the treatments that we potentially have that are out there, and then the new technologies, new developments, I think we have our own particular sandbox that exists. Right now, this is the world that we are in. If we're talking and referring over to the US itself, this is the sandbox that we're in, including everybody that's in play. We need to find a new way to overhaul that system. I don't think that there is an immediate change for it or a sudden change for it, but this needs to be a very cognizant effort from everybody in play, in full agreement to make the same goal changing. Go ahead.
Hi. You guys talked a lot about disruption, but what could be the definition of disruption? To me, that's one biomarker replaces the better biomarkers, which covers, if it were covered 20%, right now it will cover 50%. So that is my definition of disruption. All others are redistribution of the information. And if you can elaborate on those.
I am in agreement with you because when disruption occurs, it can be improvement, also can be redistribution. I'm in agreement with you.
I would say it's, as well, yeah, sometimes it's kind of, okay, so let's stop what we're doing and let's move into something completely different from there. I do think that it's an evolution of what we've been doing in terms of norm. This is how we've been doing things constantly, chronically. We're still getting up in the morning, still going to work. In the past, it used to be us walking. Now it's in a horse and carriage. Now we get to drive our, Porsches or Ferraris or something like that. You know what I mean? But it's the same thing that's happening, just an evolved format of it to make the process easier and more simplified. In my mind, disruption isn't an immediate change or something that completely shakes up the, it's not an earthquake that's immediately there. It's a gradual shift in the ecosystem.
Okay, thank you.
Well, I'll just say that the disruption doesn't need to be catastrophic either, right? Like coming back to this notion of, the nudge, it could nudge us in the right direction. So, yeah. Go ahead.
I just wanted to be a little bit of a contrarian and push back on some of the payer bashing, because I used to work at Aetna, and we would look at health outcomes. And so there might be two surgical options or two treatment options. One would have a readmit rate of like 50% and a mortality rate of 5%. Another would have a much lower readmit rate and a much lower mortality rate. And so did the second option cost Aetna like less money? It certainly did, but it was better for the patient as well. And we would try to talk to, providers saying like this, we advise you to do treatment option number one over number two, or number two, over number one. And the pushback is immense because they're like, well, who are you to tell me what to do? I'm the one treating them. I know what's best. And then when that person dies or ends up in the hospital again, as we know the statistics are going to bear out, then eventually they'll come around, but it takes years. So I would say like maybe less of an adversarial relationship with payers and really trying to find more of a common ground with them because they have a tremendous amount of information. And at the end of the day, it's in their best interest to keep their members healthy because that means that they're paying out less and the member is happier. So everybody wants the same outcome. It's just how you get to that outcome that's the problem.
So I'm going to be the adversary. I don't think everyone does want the same outcome. My insurance wanted my oncologist to do a completely different treatment on me because it was cheaper for them to have to pay that versus the treatment he wanted to do. And if I wasn't educated in the system to know how to work around the system, I would have never got that treatment. But it was all being driven by money and what was cheaper for the insurance company to cover versus what was best for me as a patient. And I'm sorry, I don't think insurance companies have the right to tell me what's best for me and what's working best for me. They have data. I worked with all of them when I worked there because I ran innovation. They have data, but very few do I see make decisions based off of what's best for the outcome over money.
Sure.
I-
I mean, and I would say that some of those,
Gentlemen,
it's
I would
cheaper
love
and
to
it's better.
continue the discourse, but unfortunately, we're out of time. I appreciate you for your question, and
Please,
if
yeah.
anyone has any further questions, you may approach the panelists with their consent outside.